I'm here at KCL to interview Professor Al Chalabi, the director of the Institute of Psychiatry's Motor Neuron Disease Care and Research Centre. I'm here to find out a bit more about motor neuron disease.
So I'm Al Chalabi. I'm a professor of neurology and complex disease genetics at King's College London. I'm the director of the King's Motor Neuron Disease Care and Research Centre, and I run the King's Motor Nerve Clinic with a massive multidisciplinary team. It would be impossible without that team.
Okay.
Supported by many staff in that group. And between us, we provide care to about 400 people with motor neuron disease per year, of which about half are newly diagnosed and about half have been diagnosed previously.
I think first things first, let's discuss what is motor neuron disease.
So motor neuron disease depends on what you mean by what is it. So from a clinical point of view, from a patient's experience point of view, motor neuron disease is a condition that results in wasting of muscles. So people lose weight, their muscles become thinner, they may often twitch, they may have difficulty speaking or swallowing, and they may trip or have difficulty with buttons and fine movements. And it's really a condition of weakness, and that weakness worsens relentlessly and progressively over a period of months to years.
So the clinical definition is described as a collection of symptoms then, but is that, in the same way that a description of a cold could be described as sneezing and coughing and hacking,
Yes.
but people actually understand what a cold is and what it's doing to your body. Do we have an understanding of what motor neuron is?
We do to some extent. Basically, the motor neurons, a neuron is a medical word for a nerve, and a nerve that moves a muscle is called a motor neuron. So there's nothing special about that particular pair of words, motor neuron. It's just any motor nerve, any nerve that moves a muscle.
Okay.
And in humans, we have a very simple circuit. If you want to move a muscle, say in your thumb, then the circuit to achieve that is a neuron which lives in your brain, and a neuron is basically a cell with a very, very long wire.
We're talking about a physical wire that runs from my brain to my hand.
So actually not quite. So in humans there's two nerves in the circuit.
Okay.
So there's a physical wire that runs from your brain to your spinal cord, and then another wire that runs from your spinal cord to your hand. In motor neuron disease, those two sets of nerves, what's called the upper motor neuron, which is the one that goes from the brain to the spinal cord, and the lower motor neuron that goes from the spinal cord to the muscle, both of those are damaged. And when I say damaged, we don't know the actual damaging process in detail, but for some reason they disappear, they die off.
What do you mean by disappearing?
So the cells die.
Okay.
There is programmed cell death in your nervous system all the time. In fact, when you're a newborn baby, you have many, many neurons with many, many connections, and the baby effectively moves randomly. That's why they seem to make all these strange movements, but only the movements that are successful are reinforced, and those pathways remain, and the other pathways disappear. In motor neuron disease, we believe it's this programmed cell death that's happening. Why should the cell undergo programmed cell death? That's the big mystery. For some types of motor neuron disease, we do know why.
If somebody determines that they're beginning to get symptoms, what should they do next? Is that an immediate cause for alarm? Who should they call, and at what stage do they sit in front of you? I suppose?
So part of the problem with motor neuron disease is the symptoms can be caused by lots of different things. So slurred speech, for example, if you drink too much alcohol, you'll get slurred speech. So part of the problem is recognising whether the symptoms are from motor neuron disease or something else. And there's no diagnostic test for motor neuron disease. So you can't go to your doctor, have a blood test, and they say, oh yes, you've got motor neuron disease. It's what we call a diagnosis of exclusion. So it has to be suspected first. And suspecting the diagnosis is itself a challenge, because the average GP will see just one person with motor neuron disease in their working lifetime.
Wow, okay.
So,
I mean, I knew it was a rare disease, but I didn't realise that would be...
Well, it depends whether you think of it as rare, because actually 1 in 300 of us will die of motor neuron disease.
1 in 300?
Yeah. So your lifetime risk as an individual is 1 in 300. So that's the same as multiple sclerosis. The difference is if you get multiple sclerosis, your life expectancy isn't necessarily dramatically changed. If you have motor neuron disease, your life expectancy is dramatically changed. So the number of people with motor neuron disease at any one time in the population is low, but the number of people who will be affected by motor neuron disease is high.
And what about early diagnosis? Does that help at all?
So the average time to diagnosis in nearly every health system in the world appears to be about a year.
Okay.
And lots of people have tried to shorten that, and no one has successfully achieved that yet. We'd like to shorten it because we think that early multidisciplinary care and early access to the only treatment for any neurodegenerative disease that has any effect, which is riluzole, at the moment in motor neuron disease that's the only treatment that has any effect. It has a very small effect, but it does have an effect. We think that the earlier you get that, the better. But we don't know that for certain.
You've been given this diagnosis, and you end up here at this care centre, because this is a research and care centre. What kind of care is offered here?
When somebody comes here, they have for their first appointment about an hour and a half consultation. And in that time, we go through their story, what's happened to them, we examine them, we look through all their investigations they may have had so far, and then we come to a conclusion ourselves as to whether further investigation is needed or what the diagnosis is.
Mm-hmm.
If I think the diagnosis is motor neurone disease, then very often nowadays the person is actually aware of that diagnosis. Now that didn't used to be the case when I was first in practice, but because of Google, people are usually coming to us already knowing they've got motor neuron disease, and to some extent what that means. So breaking bad news isn't something we do as frequently as we used to. We still do it, but not as frequently, because people have already had that bad news. So a lot of what we're doing at that point is finding out how much the person knows. So that's the very first thing I'll try and find out, and how much they want to know.
I can't imagine what you'd be able to say to somebody, who's asking, well, how long am I going to live? And you probably don't. You have an idea of what the average. You can respond by
actually
telling them
we
average.
can predict fairly well. So we've done some studies here that tell us how well we do predict,
Okay.
based on information from the very first visit, and we can predict with about 65% accuracy if someone's going to have a very bad outcome or a very good outcome.
Okay.
So we can predict fairly well, but not reliably. And I still haven't answered your question about the multidisciplinary team.
Right. Yes.
So the disciplines that we have are a neurologist, who actually in the end, after the diagnosis is given, becomes almost the most irrelevant member of the team. There's a large therapy group that are involved. So there's the physiotherapists. Their job is to make sure that people adapt correctly to any disability they've got. There's occupational therapists. Their job is to make sure that practical problems can be overcome. So for example, if you can't grip a knife and fork, how can you cut your food? So there are solutions to that, such as large-handled cutlery, self-tying shoelaces and things like that. And there's orthotists on the team, who the physio and the OT will usually refer to, who are people who can give devices, for example, a foot drop splint, so you don't trip over your feet if you've got a foot drop. A speech therapist is very important, so if you have difficulty speaking, they can help improve your communication. And if you can't speak at all, they can have various communication devices. And the speech therapist is also important for swallowing.
Okay.
So they deal with swallowing difficulty that people will often have. The dietitian is important, because people with motor neuron disease, especially if you can't swallow, will alter the texture of their diet, and at some point may not be able to swallow at all and will need alternative methods of getting calories in.
Okay.
So the dietitian can help with that. There's a palliative care specialist. People are often worried about seeing a palliative care specialist because they think it means that they're at the end of their disease course. But actually we refer to palliative services early, because their speciality is symptom control. And this is a condition where you have many symptoms. So we get the palliative care team involved very quickly. They're also experts at activating the relevant services you might need at home, wheelchair services, for example.
Okay.
Also, people have difficulty breathing at some point, and the respiratory team are therefore very important. So we assess respiration every 3 months, and then we have various red flags that will say to us, right, this person needs to see a respiratory consultant. So that's most of the team. There's a clinical nurse specialist as well, who can provide support and advice both in the community and in the clinic. There are social workers who can be involved. At King's we also have a clinical care coordinator who helps to coordinate all the different people. And we also run education groups both for other therapists and for patients.
Okay, so it sounds quite holistic.
Yes,
Yes.
that's the idea.
Yes, well, that's excellent. So, thank you so much for answering the questions so far on care and what MND actually is. But I was hoping you could now talk a bit about the research that you do here at the clinic. People are currently donating money as part of the Ice Bucket Challenge. As one of the larger receivers of grant monies from this association that people are donating to, this is one of the places you can determine what sort of thing that money does.
So the MNDA have supported us and still do very, very effectively and very extensively, not just in research, but also they fund the care centre. And the types of research that happen here are twofold. The majority of our research is trying to understand not only what is motor neuron disease, but what causes it. It's a related question. And the second part of the research is to try and see, is there anything we can do to treat it and cure it? So some of our research is trying to understand what's called the deep phenotype.
Phenotype?
Yeah.
Okay.
That's trying to understand. So phenotyping is classifying the disease pattern, if you like. And deep phenotyping is doing that in a very, very detailed way. So we have large collaborations with other colleagues, particularly in Europe, but also in the US and in Australia, trying to understand the phenotype for motor neuron disease. So we currently have discovered about 10 to 15 genes that are relatively rare but important causes for motor neuron disease. And by that I mean that although they only affect a small proportion of people, the information they give us about how the disease happens and why people get motor neuron disease is very important. It helps us build up the picture, the jigsaw. And we've also found genetic variations that are found in about 10% of people in some countries. So that would mean that I said I see 400 people in my clinic per year.
Mm-hmm.
So 40 of those would have this genetic variation. That's a large number of people to have a genetic variation that significantly increases your risk of motor neuron disease.
And if there was something that you wish the public knew about either your research or this clinic or motor neuron diseases in general, or that you feel people don't know, what would it be?
I would want people to know what is motor neuron disease.
Okay.
I would want it that if you say, this is motor neuron disease, people think, actually, I know what motor neuron disease is. It's this terrible neurological condition that leads to paralysis over about 2 years and then kills you.
Okay.
I want people to know that. And raising awareness is a really, really important thing. That's really, the ALS Ice Bucket Challenge has been fantastic for raising awareness of motor neuron disease.
Okay.
So really, knowing that ALS is motor neuron disease as well is going to be part
That must be a good starting point. Yes, absolutely. Yeah. Okay, well, thank you very much for your time.
Thank you.
I have learned much more today than I have in, well, most of the other days that I live. So thank you again. And yes, good luck in the, good luck in the good fight.
Thank you very much.
Okay.
Oh, in front of the doors.
Okay, so as you can see behind me, the research team here at the clinic are preparing to go through the process of the Ice Bucket Challenge. They're really excited but a little nervous. Sounds like it's going to be a good day.
This is the ALS Ice Bucket Challenge for the Motor Neurone Disease Association. We're the Powell and the Al-Chalabi Laboratory at King's College London. We have been challenged by UMass Med, Emory University in Sheffield. We challenged John Saville, head of the MRC, John Hardy's group at UCL, Tim Williams' group in Newcastle, Karen Morrison's group in Birmingham, and Vladimir Buchman's group in Cardiff.
Are you ready for your challenge?
Well done, guys.